Good day. This is Charles Denham, and this is our 132nd month in a row that we've had the honor of delivering these free webinars in patient safety and quality improvement. The title for today is Leadership Tools, Performance Improvement, and 100-Day Plans. I'll be your MC today and move quickly through some introductory comments, and we'll make sure that everyone has good audio right now. So I'm on slide 3 for those that have the slides. Please turn the volume up on your computer, the volume up on your speakers, and if you are not getting good audio, then you can click on the participants window in the upper right-hand quadrant of the screen and request phone, and we'll give you a toll dial-in number so that you can get a landline. So I am on slide 5. For those that are listening to this and do not have the slides, remember that you can go to www.safetyleaders.org. In the upper right-hand quadrant, you'll see where you registered or where you could register, and you can download the slides and additional resources. If you're listening to this at a later date, click on Webinars and Meetings and today's date, and you'll be able to watch the program on video and download the slides. And the page where you will land is on slide 6, and we have the pictures of Dr. Henderson and Kevin Cook, the CEO of the Mississippi Medical Center, University of Mississippi Medical Center. However, they have great colleagues with them today. Just as a housekeeping detail, on slide 7 are addresses for Twitter, Facebook, and on slide 8 is our purpose statement. So our purpose statement is that we will measure our success by how we protect and enrich the lives of families, patients, and caregivers. Our mission is to accelerate performance solutions that save lives, save money, and create value in the communities we serve. On slide 9, we have the disclosures. I won't read them. They're ample and complete. We are not covering any pharmaceuticals or devices, and no funding has been provided or ever been provided with and for this program. Our speakers and reactors are on slide 10, who we'll introduce momentarily through their bios, and Dr. Henderson and Kevin Cook will introduce their colleagues, Shannon Pittman, Candice, Whitfield, and we'll look forward to having their comments. I'm going to ask Jennifer Dingman to provide the voice of the patient and family, which we do on all of our webinars. Jennifer was the founder of Pulse, which was Persons United Limiting Standards and Errors in Healthcare. Most noteworthy is that she's a published author in multiple publications. She was one of our team on the National Quality Forum Safe Practices updates, of which there were 3 volumes. And most noteworthy is that she was one of the team that worked on the HACs, the hospital-acquired conditions, and our team worked very hard at getting those through the system with CMS, and she's one of the leaders of the team that worked on that. So Jennifer, would you please open for us?
Thank you, Dr. Denham. It's an honor to be here today, and I just would like to welcome everyone who is here and encourage you to share the recording of this webinar later. Looking forward to it, and it's so exciting. I'll hand it back to you now, Dr. Denham.
Thank you, Jennifer. So I'm going to move very quickly, probably more quickly than we usually do on the news update and last webinar's recap, so that we provide ample time to our speakers. Most noteworthy, I think, is the Modern Healthcare article that came out on the 9th of November. I highly recommend that you read the article. It has a number of comments regarding what our State of the Union is on patient safety, with noteworthy comments from a number of leaders who have spoken on our webinar here, including Dr. Don Berwick, who is what a lot of us believe the North Star for patient safety through IHI, and Dr. Stephen Swenson, who is one of the senior leaders at Mayo Clinic, and as Dr. Swenson says about the scandals that have recently happened at some of our major medical centers, once harm occurs, some leaders are not interested in hearing about it. They also maybe thinking if this got out, what would it do to our U.S. news rating, our brand, and our referrals? And I think what a great opener for leaders that are embracing doing the right thing. Our leaders and speakers today who we know are really championing the cause for performance improvement. As you go through that article, both look at the digital copy and look at the additional materials, and you'll find some great quotes, great information. It will be helpful to you, those of you that are patient safety officers, to cover the topics. And the hospital-acquired conditions preliminary data is on slide 15. And again, we were honored to be part of the team that helped get those across the goal line. And as of 2017, 20,500 lives saved, $7.7 billion. And the goal is really to get below 79 per thousand across the country. Don Berwick's quote in the article, "I'm especially disappointed that quality improvement hasn't risen to the strategic center of healthcare." And again, we have a wonderful team today where it has, where the CEO is engaged, who will be speaking today, and Dr. Henderson, formerly the head of quality for Cleveland Clinic and now chief medical officer at the University of Mississippi Medical Center, and their great colleagues. So make sure that you have a chance to read these articles completely. As we talk about, they mention the scandals at Hopkins regarding all of their hospitals, and those are part of a case study with John Nance, which we're following, with a number of other patient safety and conflict of interest stories that are being followed and developed into cases that we can learn from Hopkins to Memorial Sloan Kettering to Baylor St. Luke's in Houston, the Brigham, where I had an academic appointment, and Vanderbilt University, as well as Duke, University of Maryland, UNC, MIT. All of these organizations have had experiences that we can learn from and make sure that our honest faculty are protected. The Healthcare Innocence Project is one that we have been developing with a number of leaders in order to use digital technology, the new DNA in healthcare, to protect those who are involved, especially in patient safety accidents or in some of these scandals, because there are a number of people that are honest that are roped into them, and the digital DNA of electronic records can actually protect them. Finally, just a quick update on our MedTech program, which is focused on the first 10 minutes of medical emergencies where bystanders can care for loved ones and be good Samaritans to the public. We just had our 4th article published regarding where to place automatic defibrillators and bleeding control gear, and that was published. This article on slide 22 was published last Monday, and it addresses how the standard of care has moved and gives you a map and the evidence-based approach. Although this article is not highly detailed with references, we can provide those to you, and it addresses how we can address making sure that bleeding control gear and automatic defibrillators are available 24/7 and accessible. A couple of bullet points. Of those that have sudden cardiac arrest where an AED is nearby, 35% of the time the AED is locked up. So it's locked in a building, yet nearby. And the takeaway message is if you can have automatic defibrillators and bleeding control gear within 100 yards, which is really 1 minute walking at 4 miles an hour, you can be under 3 minutes safe, meaning that it takes a minute to get it, takes a minute to get back, and a minute to take care of the patient, both with, and what we say is we are looking forward to 3 minutes drop to shock, and that's from sudden cardiac arrest to first use of the AED while CPR has already been underway, and 3 minutes from gunshot to stop the bleed. So this article was just published, and we'll post it for download with the graphics that you can see on slide 23. And one more highlight is the opioid overdose crisis continues to evolve. We produced a YouTube video about 1.5 years ago. It's been updated with all the CDC data, and you can see it there on slide 24 to refresh yourselves. And then finally, the most recent community of practice that we've launched in Orange County, there's a group shot of leaders in our community who learned, who got Stop the Bleed training with the American College of Surgeons and American Heart Association Heart Saver. On the right is a shot of the scorecard we use, and we used 5 immersive simulation scenarios staging an accidental drowning, accidental bee sting with anaphylaxis, a opioid overdose, and taught how to use Narcan, bleeding with a skateboard accident, choking at a restaurant, and then finally drive-over accidents, of which there are 100 in our country. So I'm right on time at 10 minutes after the hour. Just a real quick recap from last month. John Nance, the bestseller, JD, and former captain with Alaskan Airlines, covered accountability and leadership. He entitled it A Perfect Storm, Mid-Course Correction for Patient Safety. We ask our audience, do you want to know more about the evolving roles of patient safety officers? Got a whopping 54% gave it a 10. You can see 92% agreed. So we will have a future webinar. Again, we decide on our topics based on our audience. You told us you want to know more about the evolving roles of patient safety officers. And on slide 28 and 29, you gave us a lot of information that you would like to have in a future webinar, which we will address with some leading patient safety officers from multiple organizations to talk about how their roles have evolved and what they're now responsible for. We asked the question regarding, do you want information regarding placement of AEDs and trauma gear, because we covered the topics of the webinar, and you can see we get a little bit more of a bell curve. However, we did have 48% agree, and so we likely won't do a dedicated webinar on this. We'll likely have a webinar because it didn't score as high. I think what we'll do is have a dedicated webinar on pre-hospital care and emergencies. You can see on slide 31 the detail that was requested. All were good suggestions, which we'll address in kind of a combined webinar. Then we addressed the issue regarding the threats to the brand damage of an institution, which has scored the highest, and Kevin Cook is on. Kevin, CEOs are ranking brand damage for various reasons as the #1 thing keeping them up at night. We asked, would you like us to address emerging threats to our hospital and individual professional brands? And we're leading an emerging threats collaborative with the top 20 U.S. News and World Report general hospitals, the top 10 cancer, top 10 cardiac, and top 10 orthopedic hospitals, and it's coming out as the #1 concern, and that might be due to a patient safety issue, a regulatory issue, or some other issue, but their brand image in the community is very, very important to them. And the topics that they gave us were on slide 34, which I won't read to you. So that brings us to the group that we have speaking today, and typically I come to that at about 50 minutes after the hour. We're going to give them another 3 minutes, and it's such a joy to have Dr. Michael Henderson and Kevin Cook both speaking to us today. Dr. Henderson is the Chief Medical Officer of the University of Mississippi Medical Center in Jackson, Mississippi. Born in Scotland, we always say that he makes good TV because he has such a wonderful accent. He did a lot of great work at Emory University, a professor of surgery, ultimately chair of general surgery at the Cleveland Clinic and chief quality officer, where we worked with him on a number of projects with Dr. Swenson from Mayo Clinic and with other leaders from some of our great organizations. Well known for helping us really focus on the practical, and we talked about it before we spoke today, the basics. He really has helped us focus on the key issues that are very important there. And the other joy for me is I've known Kevin Cook since he finished his MBA, and he's had just a great career. He's the current CEO of the University of Mississippi Medical Center, adult hospitals, as well as he's now working in tandem with the Associate Vice Chancellor. He's responsible for strategic leadership at the medical center, including the University Hospital, Weiser, and hopefully I'm pronouncing it properly, at Infants Hospital, Conerly Critical Care Hospital, Children's of Mississippi, UMMC Holmes County, and UMMC Grenada, and all UMMC-owned ambulatory clinics. Great history, being a patriot serving our country as a Marine, and he was a Marine pilot. Has an MBA, and he's been a leader at other medical centers, including Mercy Health in Cincinnati. Very gifted at performance improvement and really championed the cause of patient safety and quality as long as we've known him. And so it's an honor to have both of you, Mike and Kevin. I'm going to just turn over the presentation to you, and please introduce Dr. Shannon Pittman and Candice Whitfield, if you will, and I'm going to mute my phone.
Thanks, Chuck. It's good to be back. And when you asked us to talk about leadership and performance improvement approaches, you can't do it without a team. That's why there are four of us here. The two we've added are Dr. Shannon Pittman, who is our Chair of Family Medicine, and our new CMIO at the Medical Center. She is passionate in this space and has been a huge champion in bringing some of the work in this space to this webinar today. Delighted to have her on board. Our other participant today is Candice Whitfield. Her role is to keep me on track. She is the administrator in my office, but has been in healthcare for a while. She worked in the governor's office before she came to UMMC, and really got her interest in coming to help me drive some of the changes and things we have been doing in the CMO office. You need someone who's going to keep things on track and is going to bring ideas forward. Particularly over this past year, we've got into how do we really talk about change management? How do we get that onto the forefront? That's going to be the topic I asked her to bring to the table for us at the webinar today. So these are our two additional bits to add to our team. Can I click straight on into this? Here we go. So we're coming to you from the University of Mississippi. Kevin and I really enjoyed the opportunity to talk with you back in July. And at that time, we talked about the journey we'd been taking in quality improvement over the last 4 years. And we really touched a lot on the why, about patients, reputation, payment, and some of the results. So today, we really want to talk more about the how, the people, the culture, and the tools. I've got to figure out where I can click this forward. So really, for performance improvement, when we talked about this a little bit, we said the theme would build around today, let's talk about do we have the right people? What is the culture that you need to drive performance improvement? And bring to you some of the tools that we've certainly been putting into practice. We'll declare right up front, this is work in progress. Have we solved it all? No. There's always opportunity. And I think that's an important part of the work in this space. You're never done, and recognizing that you can always get better remains important. So really, haven't got the right people. And what we've done is divide this into 3 component bits, thinking about leaders, managers, and then the front line. Leaders are really important to help set the priorities, build engagement, and the resources, and importantly, to create accountability, a word that one uses cautiously but then builds into part of the dialogue as you move along. The managers kind of make a lot of it happen. They need to motivate their staff, be the communicators. Again, I think everyone struggles with the communication, but also come with some of the ideas and build us into success. But it really all happens at the front line. They do the work, and if we don't recognize that and figure the right way to get them engaged, we don't succeed. They have the best ideas. They know what's wrong. They know what it's going to take to fix things. And as the work progresses, we'll return to the whole concept of they need to be competitive in moving things forward, and recognition becomes an important part of that work. I keep clicking in the wrong place. So for all groups of the right people, it is about them building the teams. And we'll return to that again and again and again. It's about the teams that then drive the improvement. So I asked each of our panelists to say a word or two about have we got right people in their places. So Kevin, tell us about your hospital leadership team.
Sure. Thanks, Michael. So this gets back to the Jim Collins good to great. First get the right people on the bus and the wrong people off the bus, and then figure out where you're actually driving the bus. And for us at the University of Mississippi Medical Center, it was a journey. I've been here 6.5 years now, and really I spent the majority of my time during my first year and a half ensuring that I had the right team to take the organization where it needed to go. For me, the most critical element as a CEO at that point in time for the organization was to put on what I call my general manager hat and make sure that I got the right team around me so that folks that knew the processes that we needed to implement, believed in the culture we were trying to drive towards, and then we began to have conversations about how we were going to get there. So that getting the right team in place was a prerequisite for me before we really started to drive the organization ahead. And so many times in prior lives where I did hospital turnarounds, I found that if you don't have the right people around you, you spend so much emotional energy trying to get things done. If the team that you're working with doesn't believe in the processes you're trying to implement, doesn't understand how to implement those processes, isn't able to get results from the processes, what you find yourself doing is spinning your wheels. Once you have the right team in place, everything seems to get easier and begin to click, and that's definitely what occurred here. We've been able to put together a phenomenal team. They understand what's being asked of them. They're able to accomplish it, and then we can drive the organization forward.
Thanks, Kevin. I would like to say a word or two about have we got the leaders appropriately engaged in performance improvement. I'd highlight two things. One is leadership rounds, and again, that's just a picture of the group that we include in our monthly leadership rounds with this group, about 100 institutional leaders from the medical school, from hospital administration, clinical department chairs, service leaders from across the organization. There's a couple of hours meeting where we use that to communicate what we're trying to achieve, but we send them out to meet the front line. We send them out usually around a theme each month, but it's an opportunity to get consistent communication. When I first came here, we did these on a regular basis, 7 to 9 a.m. I think the 7 a.m. was a strange thought for some people at that point, but we've expanded those to nights, weekends. Some of the favorite rounds are the 4 a.m. to 6 a.m. rounds. And that's an amazing group of frontline employees you always meet at that time. They are the best, I always feel. So important for visibility. This is leaders meeting leaders. This is leaders meeting the front line. This is the opportunity of the front line to talk directly to them. And the front line really got good at that long before the leaders got good at talking to the front line on rounds, I felt. The second component I'd highlight is quality reviews. And this is deliberately was called reviews when we started this rather than talking about accountability, but it's accountability. And it's about having regular meetings around the outcomes and the data so that it makes the senior leaders look at the data, but it makes the teams and do with this clinical departments or with service lines sit down and realize they've got to be able to talk to that on a regular basis. So setting those up so they know their data and created a need for the departments to build their teams. The chairs soon realized we can't do all this ourselves. Let's build our teams. And you saw that evolution over time. So leader engagement is important. Those were just two of the ways that we set about doing that. Shannon, if you'd like to say a word or two about do you have the right front line or do we as an organization, I think that'd be great.
Right. So once the vision is set by the leadership team, it's really the frontline workers who sort of make that vision become reality. And so part of the goal of engaging your frontline is that if the vision is set, but these are the people who carry that out and translate it for us day to day in each patient encounter, from the phone call that sets the visit all the way down to the people who clean the room. And the goal is to make sure that you have communicated your vision pretty clearly to the front line, but then you engage them and support them with resources to be able to carry that out. But it also is about hearing their voices. And so the value of being able to engage with your front line is to have that bidirectional communication, because these are the folks who are touching our patients most often. How are they able to do their jobs? Do they have the resources and the tools to be able to do their jobs most effectively? But where is their voice? Our institution can feel quite massive for one individual. So do we have the right channels in place and the right systems in place to not only give them a voice, but also to feed back to them that their voice matters? So I think that's the critical piece for us, is having an organized structure to listen to the front line, to have leadership engaging with the frontline caregivers, but also to have that feedback loop that lets them know that we're not just out there for face value. The goal of this is really about constant iterative process that results in improving what we're delivering to our patients.
Thanks, Shannon. And Shannon's going to touch on some of the means of doing that as we get further into this presentation. And I'll ask Candice to say a word or two about how do we really get some of those messages out.
So just along the same lines as Dr. Henderson was saying with the leadership rounds and sending the leaders out to talk to the frontline staff, we felt that was very important with what we were doing in our office with accreditation, infection prevention, risk management, performance improvement. So our motto here is get out of your office, get out to the front line. So we've done that in particular with risk management and infection prevention. When Dr. Henderson started, a lot of the communication happened over the phone or through email, and our cont'd experts were not getting out there and talking to the front line. So we've changed that, and we have a great group of infection preventionists that basically work hand in hand with frontline staff on any needs that they have, or certainly it's a visible partnership now that exists that didn't exist prior to the changes that we made when Dr. Henderson arrived. Same thing with risk management. RCAs are never fun. And certainly they weren't here prior to some of the changes we made, and it was a very punitive type exercise. And we've changed that around, and not only is Elizabeth Tooney, our Director of Risk Management, have those RCAs where we've got frontline staff at them, we've got physicians, whoever's participating in that particular RCA. We're also having those communications before we have that formalized RCA, and they're happening out on the floors and trying to figure out what's happened and what's going on and where the opportunities are. So the content experts are extremely valuable, but we got to make sure that they're out there and communicating with the frontline staff.
Great, thanks. So the second thing we talked about is the importance of culture. Do we have the right culture in place to really drive performance improvement? And there's just a bunch of words up here, the improvement, the safety, ownership, et cetera, et cetera. So I really ask each of our panelists here to think about where's the culture part as we talk about some of the tools. Because I think if you don't have the right culture in place, the tools don't work. So that's how we've set this up. And as we go through the next phase of this, I'm going to ask each of them about things that they've seen important in their spaces. Along with that, we're going to touch on some of these different tools. And it's the message on this slide really is about having the right tools for the right work. You're going to need different things in different spaces, but it's about that combination of the right people, the culture, are we ready, and which specific tools we're going to use. So over this next little while, we're going to cover some of these spaces as I ask each of them to give you an update. Kevin, you're up first.
Thanks, Michael. So in terms of getting the organization to fundamentally change, both culturally and operationally, the question is, how do you begin to affect that change in the way that you want to affect it? Assuming that you've gotten the right senior leadership team in place, much like what I did over the first year and a half here, then what processes, what fundamental tools are you going to use to drive the organization forward? Because I'm a firm believer that while senior leadership can point the direction of the organization, it's middle leadership, middle management, frontline faculty that are going to fundamentally be the engine of that bus driving forward. And so how do you get that group to go from potential energy to kinetic energy and get them excited and engaged in driving the changes that you want in the organization? So over the years, I've used a process called 100-day workouts. It's an evidence-based process that came out of research done by the American College of Healthcare Executives, from which I'm a faculty member. And it's a process that allows unit-level testing, and it asks middle managers to drive innovation from their position in the organization. It asks them to become the innovators from the standpoint of driving the organization forward and changing the processes that you need to fundamentally work differently. And in each month, the premise behind it is each manager is asked to take ownership of innovation within their span of control. And given all the things that we ask managers to do on a daily basis, you really have to drive this from a senior leadership level and have senior leadership ensure that middle management knows this is part of the expectations for them embedded in their job description. Because when you think about all the things we ask a middle manager, a nurse manager to do, everything from staff their unit, hit a productivity metric, engage their employees, have patient experience, hit the quality scores. To create space for that, that's a role of senior leadership. But once senior leadership has made sure that middle management knows that innovation and culture development is part of their daily job activities, then what are you actually asking middle managers to do? And that's where this 100-day workout process comes into play. And so what it looks like is this. You divide the year up into 3 100-day cycles. You do a bit of planning, but then 100 days of execution. And you can determine during that 100 days of execution to have a particular target for the organization. And in this 100 days that we're actually going through in the organization today at UMMC, it's throughput. We're working on reducing length of stay and improving the throughput throughout the organization, both inpatient and outpatient. We have various methods we use on the outpatient side too. And it takes the organization from paralysis by analysis, where you can plan endlessly for the perfect solution, into much more of an execution mode where you're asking managers to go out, and for that 100 days, you ask every manager to change 2 things per month, addressing the issue that you're asking every manager to address. In this case, for us, it's throughput. So we're asking every middle manager in the organization to make 2 process changes a month that systematically improve the throughput of our organization. And so what does that look like? We have a kickoff session that's usually 3/4 of a day, where we set the expectations, give them data, give them tools. We break them up into teams, multidisciplinary teams. What you don't want is a team of just nursing or a team of just support services. You want to mix those groups up. If you ever walk into a manager's meeting, you always see the nurses clustered together and the support services clustered together and the ancillary services clustered together. We break down those silos and force them to work on multidisciplinary teams so that they can have peer checks and balances. Because what you don't want, for instance, is the radiology manager saying, I'm going to reduce costs in my area by getting rid of the transporters, and aggravating all of the nurse managers who say, how are we going to get our patients to you? So there's a peer checks and balances when they come up with the process changes. We ask that we try to have fun during the course of the report outs. And so once a month, we'll get everybody back together. We'll have check-ins, and during those check-ins, we ask the managers to report out the 2 changes that they're making, but we try to make it a fun exercise. It's certainly non-punitive. If the changes that they put into place, and this is critical, don't work, there is no penalty for innovating and failing, because the second you penalize folks for innovation and then failure, you'll never get another innovation. So we even have done fun things in the past, like the biggest flame out award. So somebody who tries the biggest idea, it does not come to pass, doesn't work for whatever reason, we still will recognize the daring of that middle manager for stepping out of their comfort zone and trying something in a daring way, but still came up a little bit short. That's okay, because the culture we're looking for, the culture we're really trying to drive to, is one where middle managers know that they own the system and can drive change in the system and don't feel disempowered from being able to effectively get the organization to perform in a distinctly different way. And so what we want is a culture where making change is safer than protecting the status quo. In so many of the organizations I've walked into, managers see part of their job as protecting the current status quo and fending off changes imposed on them from some larger system. What we want is change coming from the middle out as opposed from the top down. And so this makes change safer than the alternative. So we ask managers to be driving the change. We want speed of implementation. And this is nothing against Lean and Six Sigma. My first job in a hospital was a Lean Six Sigma engineer. Those methodologies work in certain areas around the organization. But what we want is minimal data and maximum execution. And by that I mean, if you want to change a process and understand whether that change is statistically significant, just catch 30 data points as a baseline, make the change, catch another 30 data points. If it's statistically significant, the chances are that you've got a pretty decent change. You don't need months of data collection looking for the perfect statistical solution to get change. So we're asking for, again, speed as opposed to the project team that looks for the perfect set of data to get the perfect change. We're asking, and another key factor in this is it builds middle management's confidence in their ability to lead the organization. In the organizations that I walked into that were the poorest performing, I found middle management teams that had given up on their ability to affect change throughout the organization, who had been given target after target, and they felt no ability to actually get to those targets. And over a period of time, their confidence in their ability to lead and drive the organization was diminished to the point where they were ineffective. They had effectively waved off their duties as leaders inside the organization. So what we want is middle managers who believe fundamentally in their ability to affect change in the organization. So we reinforce all the time, even the small successes. By the way, when we do a waste workout, and that is something where we're targeting reducing waste and cost out of the organization, the average size change is only about $7,500. But we still celebrate the $7,500 changes, even as we're celebrating the $1 million changes, and that's the way to build confidence in middle managers. The littlest things make the biggest difference in all of this. And we want to make heroes of the middle managers that show the biggest ability to affect change in this way. I always use the example of one of our middle managers here by the name of Shelley Poole. The first time we did a waste workout here, she's over physical therapy and occupational therapy in this institution. When she first did a 100-day workout in waste, she found 24 changes in 100 days worth $500,000 in PT and OT. And so we've used her over a period of time to talk to other middle managers that were struggling. We turned her into the template for how to lead and create disruptive change in a way that was non-disruptive from the medical staff perspective, and really was able to accomplish the targets we were asking her to accomplish. And then I like to joke that because we're a state agency that's an academic medical center that's part of a university, that we have a trifecta of bureaucratic excellence. And so this methodology attacks bureaucracy vigorously. And because it attacks bureaucracy vigorously, for me, that is driving the culture in the direction that we want to drive. We're always going to have certain bureaucratic barriers to what we do. What I want are middle managers that are actively seeking creative solutions without obviously breaking any rules, but finding ways of making the system work ever better on a daily basis.
Thanks, Kevin. I've got one brief question before you finish this.
Yes.
On a bit of it. To make this run, is this a full-time job for someone running a 100-day workout? So for the audience, perhaps a word just on what infrastructure does it take to drive this kind of program?
So we always have someone in hospital administration. We've had folks in the past that are essentially at the assistant administrator level who have owned this process. Right now, out of my senior leadership team, the chief operating officer owns the overall structure, but he always has someone reporting to him that works the day-to-day logistics of this, because this really is a full-time gig. It's someone that needs to accumulate the changes, track the changes, make sure that the changes that the managers are developing get put into a database. Also ensures that if we're doing, for instance, seeking financial change, that the changes that the managers put in are looked at by finance and signed off by finance, that they're in fact the dollar figure that the manager is claiming them to be. So you need someone to work and dedicate a resource. But if you're thinking about it from the standpoint of the importance to the organization, if you're picking a singular element of your organization to improve over 100 days, for instance, for us it's throughput, and that really is the top priority of your organization, it makes sense to dedicate a resource or two to ensure the accomplishment of that, because the ROI is there, the return is there, but you need focused effort and focused energies of somebody that wakes up every day making sure that the processes around this run smoothly.
Okay, great, thanks. Shannon, I'm going to ask you to tell us a little bit about what you've been doing in the frontline space. Shannon's my champion, and last week at Leadership Rounds, we deliberately looked at some of the work that she's going to describe to you, so go for it.
Sure. I think visual management is a tool that takes what Kevin was talking about in the middle manager in terms of giving them a voice and engagement and ownership to the frontline staff. So this visual management tool was introduced by one of our performance improvement engineers, and right now we have 47 locations, I think, that are actively using visual management across our ambulatory and inpatient locations.
That's right, but I will say that you have been the champion. And I think you won the prize last week as the greatest board out there.
I gave it to her. I awarded that prize.
And your people really are engaged around it.
Yes.
But you're right, we tried it in multiple locations, not all with equal success. And that's been an interesting part of this overall program. So I deliberately asked put up a lot of these things. Transplant have done a great job, but we really struggle in places like critical care and some of the hospital locations. So kudos to you for getting a team that has helped move this forward.
So we brought visual management to the ambulatory space, and we're the first clinics to do this in family medicine. And we got this tool from our performance improvement department, really thinking about how do we give a voice to our frontline folks in the clinic, our check-in staff, our nurses, our CMAs, our lab techs. How do we give them a voice? I think oftentimes, particularly in a medical institution, our frontline staff can feel like the voice really just belongs to the physician. And so for us, it was really about empowerment and ownership, empowering our current clinical leaders. So we have our RN leaders in the clinic who we've trained. But the other piece for us was also trying to break down those silos that can exist between our nursing staff and our CMA staff. So we deliberately trained both our RN leaders, but then identified some strong staff within our CMA staff to try to also elevate them from the standpoint of saying, how do we across the board say everybody's voice is important? And then we brought them in and trained them on this process with support from our institutional performance improvement team about what is visual management, what is the goal of this. And I will share that at the beginning, all of them thought, how are we going to stop clinic and getting all these patients through to meet at a board to talk about anything? There's just no time for that. And even though they were taking a leap of faith that this will make us better, along the way, it was important to keep reminding them that this is about that ounces to pound mentality. So if we do this little huddle in the morning, it's going to translate into saving time throughout the day. So in the next slide, one of the things that's really important, I think, is when we're talking about any of these tools is that the staff have to understand the why. So your frontline people have to know the vision, but then that has to be connected to something that gives them a purposeful why. Why are we doing this? It's not just something else to do. To Kevin's point, they already have enough to do around quality and this benchmark and that data, and so why give them one more thing? But I also believe that when we put tools into the environment, people will use the tools if they are useful. And so when you think about making change that's sustainable, part of that is engaging your frontliner so that they understand the value of the tool, the why of the tool, but then once it's implemented, they find the tool useful. So you don't have to keep reminding people, come on guys, it's time for visual management. They take it and run because they see where it adds value. And so the visual management process is definitely a performance improvement process that probably follows more of the lean and the Six Sigma model.
Yeah.
But the other thing that was important for us was to be able to understand that prior to us bringing it to the ambulatory space, it was inpatient. And there are some differences in our ambulatory clinics. So we were very, very, very forceful in saying that we want to understand what the model looks like and then give our staff that flexibility to adapt it to be able to make it useful for our specific space. And then we also wanted to think about how do we communicate what's happening in visual management around the huddles and on the board in a very broad space. So in our clinics, the visual management board is a board where staff can come in and basically, if they have an idea or a thought about how they might improve the process, if they have an issue that's increasing or decreasing their work efficiency, frustrations for them, impacting both staff flow, patient flow, whatever the issue is, this is an opportunity for them to write down their idea and put it on the board. Every idea is acceptable. Any idea is okay. We had a staff to suggest that we purchase massage chairs for everybody to be able to take a 2-hour break. Put it on the board, right? We kiboshed it. Get it on the board. And so it also is a way to say when there are issues that are grumblings throughout the day, when people are frustrated or voicing complaints, how do you shift culture from a complaining culture to a solution-oriented culture? There are frustrations, and we recognize that this is not a Pollyanna sort of rosy-colored, everything is wonderful, but how can you be a part of the solution as opposed to just being frustrated? So when our leaders in our clinic, our nursing staff and frontline leaders hear their colleagues complaining, they say, put that on the board so we can make it be better. So it's really about that engagement of staff, and we've been very specific about making sure that this is not just about our clinical staff. So our check-in staff, all the people in our clinic have the opportunity to the board. And I'll say before we go to the next slide that we put our boards in places where patients can see them as well, because we want our patients to understand that we are about making our practice be better. So it's open and in the public. So it's driven by our nursing leadership. The vetting happens by the team. So the team of staff come together every morning. We huddle at 8:15 at one location. We huddle at 8:45 at the other location. But the team comes in. They know it's visual management time. So they come to the board, and on Wednesdays and Fridays, we go through our pick charting. On the other days, then we just do updates on the projects that are on the board. The board is specifically designed to be about that timed and rhythm output, and so there are only 3 lanes, so you can't get bogged down in working on 15 projects at once. So the structure of the visual management tool allows you to also have a regular cadence. Department leadership is engaged and offers support. Providers are also welcome to submit ideas to the board, but the goal of this is to really be able to empower and give a voice to our frontline team of staff so that they have a voice in what's happening. It's not an isolated nursing tool, as I've said. It's for all staff. But really, it's about saying, you're a part of this. You're doing this work every day, all day. You see the problems. You know what the vision is. You know what we're trying to accomplish. But you're also touching in very close proximity to those things that are prohibited to us accomplishing that mission and making our vision be realized. So how do we hear your voice? But how do we also help you start to understand some of the challenges related to making change? So as the staff engage with these projects, because they have to own the ideas that they put on the board, they also start to learn some of the complexities around managing with multiple departments. How does funding flow? So they understand that we can't just buy $300 chairs for 13,000 people. That's not how many we have in the department. They understand what the issues are. So I think making sure that your leadership is engaged and pushing the value of this tool, but also having that flexibility, what works in trauma and what works on the inpatient side has to be modified a little bit for us. One of our biggest naysayers, I will admit at the beginning, were our providers, because the providers felt, how are you going to pull the staff away to do this huddle and that not affect my flow? So we really challenge the providers to understand that by pulling the staff away, taking these few minutes to sort of get on one accord, have this conversation, ultimately gave them back time in the process. And then it's that sustained engagement, so celebrating those victories, making sure that there's a way to promote those ideas that come out. And for us, the latest hurdle has been sharing those victories across the clinic. So when there are great ideas that come from one location, being willing to, how do we have a mechanism to make sure that we're doing those things that are moving us forward across all of our locations?
Great, Shannon. Thanks, because I think you've done a fantastic job getting your people engaged in that. I'm going to briefly run through some of the work we have done with more traditional PI-type approaches. And really, my culture theme to this component bit is being data-driven. For performance improvement work, I think that is important. And I always use the simple, timely, actionable mode for that. Data transparency is important, and I've already alluded to the importance of data review. Otherwise, why are we doing it? I'll talk briefly about the Hygiene program we put in place here, because that really had elements of the leadership, culture, performance improvement steps. And this was about every time, all the time. And as with any organization, a good hand hygiene program is more than just the physical act. The key elements of this were kind of the structure, understanding the definitions, the data, and then the accountability. And really it was about training the observers, the secret shoppers. When I came here, I said, what's our hand hygiene rate? I was told, it's 90, 95%. I said, not so sure. You stood at the corner of the hospital floor. You reckon it's probably about 50%. And sure enough, when you put a program in place, we started off in the mid-50s. But people have to trust the data. They need to understand where it's coming from. So having those definitions and setting the expectations and educations with it, here are the rules. This is how this is being done. It may be different than how it's been done before. We use the Targeted Solutions tool, the Joint Commission Center for Transforming Healthcare program and approach to this. Transparency of the data is important, and we create a new clinical intranet for doing that, and then creating accountability with the data review on a regular basis. So really the evolution of this program, which we started at the beginning of 2016, was to establish the program, train the observers, collect the data, and display it very visibly. And that's when the review started. As you can see, we started here just over 50%. But there was a fairly rapid initial rise. People said, oops, they're watching. Over the next year, it was really a recognition that we had accelerated a lot. But again, there was some rumblings a little bit of, we've got to make this look better. And it became a little uncomfortable. Some of the observations were, I'll go to the places that I know are good, so I'm going to get good results. And that's what that little dip there is. In the middle of that year, we kind of rebooted the program somewhat. So my message is you've got to watch the data. If it looks too good to be true, it probably isn't true. Figure out what's really going on. So reconfirming expectations, and this is when we started some of the just-in-time coaching in this program too. Oops, what did I do? And as we moved into the next year, this just-in-time coaching became part of it. We kind of had stalled out in the low to mid-70s. And the just-in-time coaching was training people to stop providers or caregivers if they weren't doing hand hygiene. What's the barrier? Why didn't you do it? Help them understand. People, oh, I forgot. But there are barriers. It's not as easy as it seems. I'm taking a zillion things into the room. I'm doing X, Y, or Z. But also it's about beginning to get the team building going on. If the staff goes in and doesn't wash their hands, guess what? The residents and the students don't do it either. So it's building some of the team, and this way the just-in-time coaching became important. And really cranking up the accountability in this phase was also important. And finally, this year, really increasing the transparency of the data. We had a couple of locations that really were kind of stalled out. We're different. We can't do that. We're not like this other location. But really just putting it out there, very transparently, and saying, same rules are applying. This is about our patients. We all need to get to a higher level. And that rise over this last year, I think, has largely been driven by increasing the transparency and increasing the competitiveness. You don't like to be last. And those that were last are no longer last. And increasing the recognition and getting into the sustainment phase of the program became important. So it's an evolution over time. I seem to have lost my ability to switch forward. What have I done wrong?
You made it bigger.
Okay. All right. Transparency this year has really been about this red, yellow, greens. And this has been on the front page of the clinical intranet. And this was driven really by this stalled around 80% compliance in the latter half of last calendar year. And as soon as we started doing this, we came on up, and we've been hovering between 87–90% compliance. And really, that's about as good as you get if you've got a really rigorous secret shopper program going on there. And when we started this program, we were stalled in the adult hospital. Children's were blowing it out of the water. They were doing a great job, and have continued to do so. But the nurse managers in the adult hospital really took it to heart, and they didn't want to be the red ones and be the last. And they've moved up to the green now. So you see this progress over time, largely driven, I think, by the access to the data, which is put out there by location and initially by clinical departments allocated by location as well. So really, the lessons learned in this kind of space is some of these programs take time. Understanding where you're at the different phases of it. I would say for the hand hygiene program, about halfway through, I'd say it's no longer about the physical act. We're now talking about the culture. This is where you could see the areas that were struggling, barriers that needed to be removed, and developing the trust. Do they really believe the data? Do they trust the observations? Do they respond appropriately to the just-in-time coaching? also is listening to all the providers out there, hearing them, changing how we did things as we went through the program. And I think they do believe it and trust it, and I do believe this is real at this stage. It's the combination of that physical act and the culture. And knowing when to move to the next phase. If I put up that level of transparency at the beginning of the program, I think it would have crashed. So recognizing when you're ready to take another step in the program becomes important for programs like this. So I'm going to move on to ask Candice to tell us a little bit about what we've been doing to try and pull a lot of these different programs together. So Candice, take it away.
And to thank you. And to Dr. Henderson's point about recognizing when it's time to make a change, I think that's what's going on right now in regards to the initiative around change management. So if you've heard, we have some great tools that we've instituted here at UMMC, from 100-day workouts to visual management to the just-in-time coaching. But what we've started to realize over the past year is that we have a lot of pockets of performance improvement, but no common language across the health system in regards to that in performance improvement. So we've been working with the Center for Transforming Healthcare with the Joint Commission on some of the high reliability initiatives. And so through that work, we learned of their change management program. So I don't know if any of you are familiar with Dr. Chasson at the Joint Commission, but this is a great quote that he has that says, "Process improvement in healthcare is not rocket science. It's actually much more difficult than that, because rocket science involves getting machines to behave as you want them to. With process improvement, you need to change the behavior of people." Amen. Because I feel pretty confident that many people on the phone have had that similar sentiment. If they just do what I ask them to do, it'll all be good. We can get it done. And so we have, we certainly have those challenges here. And so in working with the Center for Transforming Healthcare, we learned of their change management program. And why it's so appealing is it's really the focus is on people. And I think throughout this presentation, that's what we keep harping on, whether it's needing leaders buy-in, or whether it's the fact that only the front line can really make the changes, or you need that innovation from the middle management. We keep coming back to people. It's not the process. It's not the solution. It's those things don't change culture. It's the people that change culture. And the change management is really focused on the people. So in addition, the Facilitating Change program that I'll talk about in just a second really fosters buy-in and support for change programs that you have at your institution. In addition, it's gaining acceptance and accountability. As you all know, I'm sure at your institution, you've instituted something and it did great for 2 to 3 months, and then in about 3 months it started to, didn't have the energy that it once had. Well, maybe because there wasn't that support system or accountability in place for it, and change management helps with those things. And again, in addition, it really engages those closest to the solutions. So if you don't have those that are actually doing the work involved in designing the process or the solution to the problem, it's going to fail miserably. So change management helps with that, and then empowering staff and sustaining those gains and improvement. So again, why we went with change management, and we started to recognize that need for a common language around performance improvement. Again, this pocket, it's much similar to what Kevin was talking about earlier, the siloed efforts that we have across the institution. We saw that with performance improvement and really thought that we needed a common language around it and more of a standardized approach. Also recognize that link between culture and change management. Again, I'll reiterate it. Only the people can change the culture. You can't, there's no widget, there's no process that can fix it. So change management helps with the buy-in and acceptance for the new ideas, and really makes those meetings more productive. And again, I'll get a little more detail about that in the next couple of slides. So the first thing we did is, this was back in January of this year, we brought together senior leaders to participate in the Leaders Facilitating Change training. We know, and we've, each panelist here has stated the need for the frontline staff to actually move the ball and the middle management to support and really come up with those innovative solutions. But you have to have the buy-in of the senior leaders. So we started with them. So we got a group of 50 together, and we had the center come on and do a facilitating change training for us. It was 2-day training. We committed that each leader had to commit 2 days of their time to participate in this training. And what we did is twofold, really. First, it was we needed them on the same page to understand what we were doing. We certainly got the buy-in of a select few of the C-suite here at of the health system, and they got it. But you needed a much broader, sorry if y'all are hearing the helicopter. I apologize. It's flying right over us right now, so I apologize. Much broader leadership engagement than just the 2 or 3 we had talked to. So that was the first and foremost, for them to understand the concept. What are you doing? When you're talking about facilitating change management, why are you doing this? What is it? And then secondly, we wanted them to start learning the tools that we were going to implement across the institution to help develop that common language and that standardized approach. I mean, they are just as useful for someone sitting in a C-suite to use as it is a frontline staff, and we wanted to make sure that everyone was on the same page. So after that training in January, we then instituted our first wave of change leader training. And this is where the rubber meets the road. These are the people that are actually going to be the change leaders in the institution. So we just recently had this in September of this year. We had 20 individuals participate in the change leader training. The way we selected these individuals was we asked leaders that participate in Leaders Facilitating Change training to nominate individuals, and then we also, next slide, we also had self-nominations. So we got, I don't know, 45, 50 names of people that were interested, which I thought was great because, again, this is not something anybody knows much about at the institution at that time. And so we got 45, 50 names, and we selected those 20 that would participate in this first wave of change leader training. So we did that in September, and it went great. It was a 3-day training. Again, asking these middle managers and some of the frontline staff to pull themselves away for 3 days is a big time commitment. So luckily we were able to get everybody to do that. And things that they were going to learn in the training are really that facilitating. So you're switching on me. Okay. Things that they were going to learn. I'm like, what are you doing? Things you're going to learn in the training are how to recognize the link between culture, process improvement, and change management. And again, I can't stress enough that that's the piece that we're really trying to affect here is the culture. How to employ those core concepts of facilitating change management, and then the tools. I mean, we have great processes in place like the 100-day workouts and visual management, but these are tools that can be used in meetings to facilitate meetings. Change leaders are not project managers. And I want to stress that again, they're not project managers. You still have executive sponsors and team leads for most of your projects. These are unbiased, objective facilitators that come in and help the group get from point A to point B. So, and they do that through using this facilitating change model. Now, I'm going to say, none of this is magic. I mean, I'm sure most of you on the phone, when you've worked on a project, utilize some of these components every time. What's so nice and so effective about this model is that if you notice through each of the components, again, it's weaving that people aspect through it. So when you're planning your project, you got to make sure you engage all the stakeholders, people. With the Inspire, you have to paint that convincing picture. You have to make sure that people understand how it's beneficial to them. It can't just be, as Kevin said, you can't just have the C-suite telling frontline staff how to do something. If they're not bought in, engaged, it's not going to happen. Launching the initiative, big point of failure right here. Certainly, again, ideas are great on paper, but sometimes when you actually try to execute them, they fall a little flat. So this change management piece allows you to bring in the appropriate stakeholders to communicate the initiative, the project, the process, whatever it may be, to ensure it's successful launching of it. And then to support, again, another big failure point. You can implement any type of process change or whatever it may be, and if you don't have that sustained the ability to sustain it, whether it be through resources needed, whether it be through the accountability piece to ensure it's happening, you know, it's highly likely that it's not going to be successful. So why we, again, people, I can't stress it enough. You know, this is why we decided that when we saw those pockets of different areas of performance improvement, we really needed that common language. We needed more of a standardized approach. And we felt very strongly that change management was the way to go because the central focus of people, the buy-in, and the accountability. So as you can see, here are some of the value of change management. You've got the innovation. Kevin spoke about that, and it's something he's very passionate about here at UMMC, is that we want to have middle management and frontline staff that are innovative. Trying to, you know, if you buck in the status quo, we try to reward that, not punish it here. Improvement, I mean, that's the name of the game. Obviously, we're trying to make sure that we're, you know, when we're working on these process improvement projects, that we're improving or making things better with the opportunities that we see. The team building, the standardized approach. I mean, for, you know, no other reason, if you can make a meeting more productive and effective, that's fabulous. And again, a lot of the tools that these change leaders learn that help these tools ensure that the meetings move how they need to move, and they're not just, you know, it's not just wasted time, which happens with a lot of meetings. And growth, progress, and we're always chasing zero harm here. That's, you know, first and foremost is patient care, and so patient safety. So we're always chasing zero harm.
So thanks, Candice. I think, to me, this has been an important component of how do we pull a lot of these different programs together. As Candice said, you kind of find you had performance improvement going on in our space. It's going on in some of the hospital administrative space. It was going on in pockets here and everywhere. So trying to get everyone on the same page is a challenge, and I'm sure many of you face that same challenge. So really, just in wrapping this up, you know, we've been at this for about 4 years, and are we making progress? I would submit we've come a long way, but we're far from done. I feel very good about the people level of engagement. And when we make change, you know, everyone says change is fine as long as you don't change me. And you feel that. But people now recognize when you're doing something different. They may like it or not like it. You can hear about it. At least they talk about it. Culture, I think, has continued to evolve. And I think we're on that journey of how do we try and make better use of some of the standard tools. And we have some projects that are significant Lean or Six Sigma type projects. But I didn't really want that to be the emphasis of this presentation. I wanted to bring in some of these other things. Visual management has clearly been valuable in helping build the frontline engagement. The 100-day workouts are particularly valuable and important in some of the hospital operation arenas, but I think we need to incorporate more of those into some of the quality arenas. So I think the whole change management does bring all these tools together. So I would say I'm pleased with the progress. Candice, how do you feel we're doing?
Me too. And as Dr. Henderson said, it's funny that he made the point that you can change, don't change me, because we're in the process right now of revamping our institutional scorecard for 2020. And so we had a focus group yesterday with nurses and physicians to ask, and, you know, one of the nurse managers looked at me, she's like, I mean, I just got used to this. Why are you changing it? So, you know, and again, after a conversation with her as to, you know, now we're trying to different objectives, trying to do something differently, we got to the same place, but it's just back to, I think we've made a lot of progress, but it's always a work in progress too, because people don't like change. I mean, I'm as guilty of it as the next person, but we are continue to move on that path.
Yeah. So we lost Kevin and Shannon because there's another strategic retreat going on campus today, so I'm afraid they've had to leave. But Chuck, we're at the end of this, and we'll be happy to take any further comments and questions.
Fantastic. What a great presentation. What I'm going to do is, as soon as I have control of the slides, I will take us through very quickly the survey questions. Kyle, can you give me control? There we go. And I'm going to have you put the survey up, Mike, and then we'll come to questions and give you a chance to kind of comment on each other's statements. But the first is I would like another webinar on performance improvement plans and tools, and give us we're looking at Net Promoter Scores, so if you really want it, give it a 10. And then the topics that you might wish to cover, and we'll put those in the free text entry. So Kyle, if you could bring up the survey questions. And the second question is, I would like another webinar engaging senior leaders in patient safety, and the topics I wish to have covered in a webinar on engaging senior leaders. And so this gets at the question, which I'll come to in a minute, about did you engage your board, and if the safety and quality leaders love what they saw and they would like to get senior leaders as engaged, Mike, as you and Kevin and your other leadership team members are, there's probably a right way, a lot of wrong ways, maybe a lot of right ways. It would be great to understand how some of the approaches that you guys have come up with can be incorporated into their programs. And so we have those two questions that we're asking. And then, and so what we would like people to do is to respond to the survey questions so that we can get a good answer of whether this is an area that you would wish to cover. I'm going to go to the question Q&A, and those of you that have finished the survey, go to the Q&A section and ask your questions. Liz, and I'm going to mispronounce her name, but Liz Adami asked, how do you decide on which issues to address? Second question is, how do you keep staff engaged when their ideas are not chosen?
Well, I'll take that first, and then Candice can add to it. I think in deciding what you're going to address is always a challenge. When I came here, for me, it was relatively easy in that I said we need to address institutionally important gaps in performance. And I think some of that, I believe you've got to take off some of the public reported data and metrics. So much of the work we've done here is focused around some of the classic things, hospital-acquired infections, readmissions, mortality, etc. So I think you stick with many of those basics, as you've heard me say before, Chuck. That gives you a good starting point. The danger and risk is if you start into too many specialty spaces, you don't always fix some of the basic underlying things that are important to everyone. And there are some certain common themes. And I hope that part of the message we've given today is that no matter what, you've got to have engagement. You've got to get the right people on board. And a lot of it is about the culture. And then choosing the right time to take the next step. And to Candice's last point, the fact that we're updating the scorecard and, making it a little harder, but bringing in some new concepts, I think is important. You can't just make it static. I think thinking about how do I keep stretching them a little bit further becomes important.
Candice and Shannon, do you have any other comments you'd like to add to that question? The two questions, actually, is how do you decide on issues, and how do you keep staff engaged if you don't pick them? Pick theirs.
The staff engaged question, and I'm assuming that it's around visual management, I would think, but I'm not sure if that's. So speaking in regards to visual management, I think showing them the benefit of the projects that are picked that also affect them and the clinic as a whole. Because to your first question, you have to prioritize. You can't do every project. It's just not possible with resources and bandwidth. But I do think motivating staff when their projects don't get picked is important, and showing them, first of all, having them maybe engaged in another project that is not theirs, but showing the importance of their role and how they can be a productive contributor to whatever the other problem is. And then two, on the visual management boards, there's a parking lot, so there's the opportunity maybe not to address that that problem or issue right at that point in time, but to put it in a parking lot. Maybe you can get another time when the resources allow for that, so you're not completely shutting down that idea, but you're delaying it to maybe a later date. But certainly trying to engage them in another way, whether it be with another project or showing the benefit of how whatever we're working on now is beneficial to the whole, and thus we need your input, attention, and your continued participation.
Yeah, no, I agree, and I think if you have too much, nothing moves.
Yeah.
And I think one of the themes I have kind of stuck with is having focused goals. And some people didn't like that. When I came, there were, I think, 20 different quality scorecards. Everyone had one they liked. I didn't think that was a very good approach, so we simplified it down to the one institutional scorecard. Now, when you look at it, you can start building important local activities off the institutional scorecard. So you've got to encourage them to move on into, okay, is this something that's going to contribute to the good of the whole? And then how do you add something that's also valuable to you and your local location? And a lot of it is communication and dialogue.
Great, great. And you know, the bestseller, who's won actually the Guinness Book of World Records, Purpose-Driven Life, written by Rick Warren, is one of his success factors, he said, was that his mentor was Peter Drucker. And when he went to see Drucker, he said, I will mentor you if you promise me one thing. And Rick Warren said, what is that? And he said that you tell me, the first thing you tell me when you come to see me is one thing you've stopped doing since you saw me last. And I think we're so good at spawning lots of projects, but as you say, you know, when you have so many, it's just sensory overload. The question that I have for you, Mike, is I was so impressed by what you implemented at the Cleveland Clinic when you would have rounds with the boards. So you would have board rounds, and rather than me tell the story, would you tell the story of how that worked? And my question is, that's the first question. Second is, have you implemented that there?
The board here is very different to the board there, point number one. Point number two, it didn't happen just like that at Cleveland Clinic. It was an issue of trying to get some of the believers engaged initially. And when we first started engaging the board of the clinic, I had two board members who really got it and came out of industry where they had seen significant performance improvement work. So getting them engaged. By the time we left, you had to fight to keep board members off the quality, patient experience, safety subcommittee of the board. They were very engaged. And I think having board members join you on some of the leadership rounds is a valuable exercise. I've offered that to our board here. Our board here, as a state institution, is the oversight board for all of the state universities. So it's a very different approach to the board here. Frankly, they've come a long way in the past 4 years from really not hearing anything other than the problem bits of patient safety, outcomes, quality, to getting quarterly reports, understanding what's going on, and asking much better questions about it. So I think your boards are all going to be variable. I think you've got to figure out where they're at and build to the next level. As you get them more and more engaged, getting them on site so they can become part of leadership rounds, I think is always a valuable bit. The fascinating thing to me about our leadership rounds here has been, 4 years into it, our leaders are still all engaged. Our frontline get upset if they get left off rounds. You haven't been here for a while, because we've tried to split it out into broader locations over time. That's a good sign, but it's tough to keep new things going and to look for new ideas.
Gotcha. Great. And thank you for clarifying that. Yeah, you have a totally different board structure there as I reflect on that. Absolutely. The next question, I've got two questions for you. And the first question is, for organizations that want to implement some of the tools that we've seen today, how would you recommend quality and safety leaders in our audience to broach the topic and try to bring these new things into their organizations? And anybody, any one of you, any of the three of you, please comment.
Well, I think, you need the leadership support. And I think being careful to do that, because if you don't have that and you try and implement something and the leaders turn around and say, what was that? It's going to die. So I think when you're wanting to do something new, it's having them informed. It's not what I tell our leaders, our executive sponsors for programs, things, I need 5 minutes of your time here or there. I need occasional visibility to say this is important, that I as a senior leader am supporting this. I say we'll put structure and support around the program to move it forward. And I think one of the things I've seen at Cleveland Clinic and felt here, a lot of this is about having an appropriate infrastructure. It's not overburdening it, but if you don't have some structure and organization to it, things won't take off, they won't be seen through, and they will not be sustained. So having some infrastructure there is important. So I think that, to me, is the main key for all of you trying to do something new and different. And I think all of the tools we've talked about, they're all proven things out there. You can Google any of them and find out information about them in more detail.
But I think what's key, too, and what Dr. Henderson did a very good job of when he came into this role here, is timing. I mean, we weren't ready to do certain things at certain times. So, for example, he spoke of there was 20 different scorecards when he got here. So his first large initiative was to make sure to consolidate those into one for the institutional scorecard. We were ready at that point to do that. Now, if we had to try to implement what the new concepts that we're doing right now, I mean, simple, timely, actionable data was his mantra. If we were trying to do some of the things we're doing now with the scorecard, then it would have failed miserably. Change management, that would have failed miserably 3 to 4 years ago. We had to get everybody bought into the, the concept of, all right, we've got performance improvement. We're doing different pockets of work. All right, keep doing that. Get used to it. Get accustomed to what you're doing, and that this is going to be. Try to integrate this into your daily work. And now we're trying to create a standardized approach across the institution. So I think timing is huge for these things. And again, having those open, being transparent, those open conversations with leaders, they need to be bought in, but get their opinion too. Are we ready as an institution? We ask ourselves that question. Well, yeah. Once a day, we ask it 40 times a day. Are we ready? Are we ready as an institution? So I think timing is huge.
The other point I would add, Chuck, is that I think the tools and things we've talked about, they are applicable way beyond quality and safety.
Sure.
They're important for operations. You heard some of that from Kevin. But you need to get some of these things into the finance side of things, too. We struggle with that.
Yes.
How do we get our finance people to think differently and engage in some of the improvement work that can be done? Because we don't educate the front line about some of the finance things and get them more engaged. You're not going to make progress in some of those other spaces. So I think these are tools that I believe are applicable broadly across everything. It's the way you need to do your work every day.
Right. Are there other, so my second question, I know if Dan Ford was on, and you know him well, Mike, from being involved in many things with us, who's also a patient advocate that's part of we have a Saturday morning team of patient and family advocates who've lost a loved one and have been very, very active in participating in the patient's voice. Have you, or would you consider, or does it make sense to have a patient and family advisory board or committee or whatever you might call it to provide input in this area? And then the second part of the two-part question is when you have a root cause analysis, are the patients and families invited in, not required, but just invited, as our invitations extended to them to get have their participation.
Yeah, the family advisory councils, yes, absolutely. I think those are important to have. But again, as you put those together, some of the themes we talked about today hold. You've got to have the right people. To build those with the wrong people is courting problems and disaster. And again, I think the culture into that space is important. But giving them the opportunity to do some work and some simple projects. In Children's Hospital here, for example, and Hygiene and the Family Advisory Councils, they can be some of your best advocates of really bringing it to the patient. They're the best observers, but the patients are scared to speak up about it until you get the culture to the right level. They can indeed have an impact. So I think those are essential. We have not evolved to the point of having patients and families on our RCAs. I do think there are some situations where that should be done. I think it is an important concept moving forward. But again, one needs to be careful. When I was at the clinic, we did try some of that, and I saw it misfire a couple of times, and that concerned me, where patients or family were very much there to play their agenda rather than what is an RCA really all about. It's about understanding what went wrong. It's about a learning opportunity rather than a punitive opportunity. And I think it's important that any families getting engaged in that, it's made crystal clear to them that that is what we're trying to do, rather than you're here to criticize it. You're here to help us do it better and make sure things don't go wrong the next time. So I think there are nuances to this, is my message.
Great point. We agree, over the years working with patients and families, just like any team, as you say, picking the players that can provide that influence, because so many are still
you've had some great champions, Chuck, out of that space, and some of the people I've met through you and your organization, some of the families and patients, they've been incredible. Really get it, but they're doing it for the right reasons.
Right. Sue Sheridan and Dan Ford and Arlene Salamandro and Becky Martins, along with Jennifer Dingman, fantastic. So as you look at going forward for 2020, what are the focus areas, your strategic focus areas for 2020 as you're gearing up your plans, which you probably already have? What are the big ideas for 2020?
Well, I think it's continuing the agenda that has been in place, as we talked about in the last webinar a few months ago. Chasing Zero didn't come in until we were into our third year of the program. That got a lot of traction. It was the champion things over the past year. Taking that to another level, and how do you really start to bring in ideas around some of the employee safety issues? So I think you've got to continue to expand. Many places have done these kind of things. I think our big thrust this year is really trying to push some of the change management program so that it helps our organization change just how we do business as a whole. Standardizing meeting facilitation, standardizing some of our overall approaches, and increasing the engagement and the voice of the employees overall is what I see as one of the most important opportunities. Candice, I don't know if you got stuff to add to that. I think.
No, I agree. I mean, but I think that's at the institutional level. Certainly in the CMO's office, we're chasing Zero, and then some of the institutional metrics that we're looking at. But I do think it's important, to Dr. Henderson's point, you have to refresh these. You have to constantly keep people engaged. And so, we're certainly at this point talking about how the things that we've looked at over the past 2-3 years, how can we refresh them? And, we're looking at ways to look at process outcome measures and then adding process measures in there. So just, constantly keeping people engaged is important.
I think the other thing that should be on everyone's radar screen, Chuck, at the moment is the changing face of healthcare. It is getting harder and harder as resources get tighter and tighter. And, that was a rude awakening call for me when I moved from Cleveland Clinic here to see from a relatively resource-rich environment to a struggling environment. But I think everyone in healthcare is struggling to how do we get these programs are great. Everyone will agree with them, but it takes some resources and support to make them happen. And I think the challenge going forward for all of you is how do you get the resources to keep these kind of programs going? And I think that's why it has to just become part of this is how we do our work every single day.
Well, that is terrific. One last question, and I think you and I, Mike, have spent a lot of time with Steve Swenson and got to see how the Mayo Clinic finance teams would independently and in isolation from the performance improvement groups would come up with the ROI analysis, and they were getting 5 to 15 times ROI on what they were focused on. Any advice to the finance folks or working with finance folks to be able to make a good business case? Because, I know Kevin Cook is a very financially responsible leader and will always want to see, what the numbers are. And many of our leaders are, really would like to see what is it going to cost, can we do it, and in the end, how worth it will it be so we can put these precious resources on the right things? So last question is about finance.
Yeah, I think ROIs on these is hard. So much of this is cost avoidance.
Yeah.
It's how do you stop the bad things happening that are costing us so much? And I think in this space, that's what I struggle with in it. And I think you can come up with all kinds of numbers on paper, but how real are they in practice when you look at the bottom lines on your quarterly or monthly financial reports? So, Candice.
Well, I would just say that I think that, your reference, I believe, was to Mayo, which is light years away most of the probably institutions that we're speaking of. So I think the best first step is just getting finance involved in the conversation. And that's what we've tried to do a little with this change management is we certainly have some of the finance representatives sitting on the task force, the steering committee, and then we certainly have invited some of those to participate in some of these change leader training. So, I do think that the ROI and looking at the financial side and how you reap the benefits or the cost of these programs is important, but I think even taking it a step back and just having finance at the table when you're having these conversations is the appropriate first step. And I know that we struggle with that and are continuing to try to do that, and certainly will be something we try to do over the next year.
Well, that's terrific. What a great note to end on is just getting them in the conversation is terrific. So what we'd like to do is thank all of you for, again, just a terrific presentation. The good news and bad news is that you'll probably get such high ratings that we're going to bother you to come back and talk to us again because you offered such great experiences. Thank you so much. Please share our thanks to Kevin, who I know had to go to another very important meeting. I want to remind our audience before Jennifer closes us, I'd like to remind our audience that Dr. Casey Clements, one of our global leaders in sepsis, who's an emergency medicine physician, also has the role of leading some really pioneering work in workplace violence at the Mayo Clinic. He calls himself a recovering researcher, very, very capable leader, and we'll be sharing, I think, some great insights in our December webinar. So we hope all of you attend with us. And I saw another question just pop up. The recording will be available within 3 business days so that you can share it with your colleagues. We're already getting good response, Mike, to things with the questions. So God bless all of you. Thank you so much. And if you all could just stay on for a couple of minutes so we can do a performance improvement loop to see how we could have done a better job for you, Mike, that would be great. Jennifer, would you please close us?
What a wonderful webinar, as always. Again, thank you all so very much for being here today, and please share the recording with your colleagues. Looking forward to the next webinar, and I wish everyone here a very happy and blessed Thanksgiving. Thank you all again for being here.